we strongly believe, all of us, but we as European community of gynecological endoscopy, we strongly believe that endoscopy, and as Grigori said before, hysteroscopy is an invaluable tool for evaluating the uterine factors for infertile women. We strongly believe on that, me, Luis, and Sergio Aimovic, but with the great support of Grigoris, Ursula, and Rudy Campo as well. We arranged a Congress a few months ago, probably some of you were present, but this Congress has a little bit put more light on the importance of uterine factors, because as Grigori said before, I mean, people sometimes minimize the value of uterus in reproduction. So the general tendency of modern reproductive medicine has always been to focus only on the embryo. But if we imagine that the uterus is just like, I mean, a room, so we can have that lesion that can alter the morphology. Sometimes you have a pillar inside a room, or you can have something inside the cavity. And I'm sure that Rudy will speak about the lesions that do not alter the morphology of the uterus, but they can create problems inside the cavity. And more difficult to be detected, what we call the subtle lesions. I will focus in this 15 minutes talk on the lesions that can alter the morphology, the shape of the uterine cavity. And we will discuss how to treat in a very pragmatic way, but more important, when there is the indication to treat these anomalies. Of course, we cannot analyze all the uterine malformation, but we will focus on the two more frequent, the septate uterus and the dysmorphic uterus. How to treat? You know, we all started with the monopolar resectoscope, standard size resectoscope with equatorial loop. We learned the technique of cutting this midline septum in the uterine cavity. I remember that when I started my hysteroscopy training, there were bipolar electrodes, disposable, reusable, that we could use to cut some small septa. And I can tell you that probably uterine malformation has been my main focus throughout the years. And during the last 20 years, we have seen a tremendous advancement in technology, but even in the cooperation of 3D sonography with hysteroscopy, new technology in hysteroscopy, new advancement in the knowledge of the histology of the septum. And this is the reason why I modified my technique up to this technique, even because when a wonderful, I define miniaturized bipolar resectoscope, the 15 French bipolar resectoscope came in the market, I immediately thought that probably it was the best indication for this was the septate uterus, because we can also use the bridge in order to put the palpator inside and to see if it's important. So how many millimeters, centimeter we have cut. We can also put inside the mini resectoscope miniaturized scissors to refine the base of the septum. And I think that at the end, when you have a result like what you see here, you can be happy, because even when you stop water, you see that it's bleeding on the surface. You arrived at the end, and you can put, and we strongly believe the importance of gel to avoid intrauterine adhesions. But apparently, this surgery is very nice, but who does hysteroscopic surgery knows that sometimes this surgery can be very frustrating. The same surgery that I showed you before, so everyone probably agreed that the surgery was done in a good way, because at the end, even when we check with immediate sonography after surgery, so we think that we did a great job. This is the follow-up after 2 months. You see that both at sonography and in hysteroscopy, there is a residual septum, a recurrence of septum. We don't know how to define. But this means that even when you do a perfect surgery, the results can be more or less frustrating, but you need more or less a second step to do a good job. This is a slide that my friend Luis Alonso gave to me, because in order to show how artificial intelligence can be a valuable tool even in hysteroscopic surgery. And I think that in metroplasty, probably artificial intelligence will help every surgeon to do a correct diagnosis, to standardize surgery, and also to offer the possibility of a correct, accurate post-operative evaluation. But why it can be frustrating, the surgery of septate uterus? Because there are some factors that are not modifiable, because not all the septa are the same. Read this editorial of Grigoris Grimbidis. It's amazing because he describes that septa are not all the same. There are septa that are more fibrotic, less vascularized, and other septa, more difficult to be treated, that are more muscular and more vascularized. And probably this is the reason why the results of surgery can be different. And with my friend Stefano Betocchi, we also did a study in which we analyzed the histology of the septum, and now we know that the septum in some portion has the same histology of the myoma. And this is the reason why probably we don't need only to do the section of the septum, but even the resection of the exuberant tissue on the fundal area, anterior and posterior wall. And the school of Gianpietro Gubbini and Paolo Casadio has perfectly shown with the study of 3D sonography that it's not a matter of the surgeon, but you need the second step of your metroplasty surgery, because there is a remodeling of the uterus itself. That's why in our protocol, we generally say the patient that she needs a 3D sonography and a follow-up hysteroscopy 2-3 months after the surgery. You have to wait for the physiological remodeling of the uterus, and then you are going in outpatient setting to do both the sonographic control and even a follow-up hysteroscopy in order to cut, as you seen before, with blunt or sharp scissors, the residual of the septum. But more difficult is to understand when septa should be treated. Of course, you understand that I am strongly in favor of the treatment of septa, but as a man of science, we have to analyze what literature says, and we have not to be, fond of our good or less good surgery. We grew up, since I was a young trainee, with the conviction that if you treat the uterine septa, you can improve reproductive outcomes. But then we have seen that there are some papers, mostly from the Dutch school, that came on a very important journal, and even a very strong alert by Human Reproduction in order to say that septum resection does not improve reproductive outcomes. And so the community went in a nightmare, because we strongly believed that our surgery was useful, and then our conviction were dismissed. The problem is that the article should be read in the proper way. And when, you read an article, you should analyze in a critical way. We cannot analyze in depth the many bias that these two trials, one was a retrospective trial, another one was a randomized trial, had. Many bias, but the most important, on my opinion, is the surgical bias, because you see that the number of average procedures per center per year was less than half procedure. So you can understand that it can be not so bad if hysteroscopic metroplasty is not a procedure for a skillful operator, but we have already seen how frustrating, even in expert hands, can be the hysteroscopic metroplasty. And we surgeons, we always think that we are expert only when we do a lot of procedures, but it is not real. We are really surgical expert when, according to our surgery, we are able to improve the reproductive outcomes, in this case of Our Lady. This is the reason why I analyze my data, and I have seen that in my personal series throughout the years, changing the technique, increasing my surgical experience, I could increase significantly the live birth rate per procedures throughout the years, but even time to pregnancy was significantly reduced throughout the year. So it means that probably the technological and technical advancement and even the better knowledge of the histology of the septum helped me to become more and more expert in this topic in order to improve reproductive outcomes of our lady. Even more challenging is the problem of dysmorphic uterus, because before this classification system done by Eschre and SJ, we only had the class 7 of American Fertility Society, but we all believed that this T-shaped uterus was only related to the use of the ethyl stilbestrol. Then we have seen that in our clinical activities, we see these uteri that have a normal a normal outline of the uterus, but at the end they have a narrow and irregular inside cavity, and this is the problem for the pregnancy. We started, I personally, me with my group, after reading some papers, we described this technique that is not an innovative technique, but we just standardized the surgical step of cutting the isthmic rings in the lateral wall of the uterus. I already knew that my friend Rudy Campo and Jaime Fierro in Spain, they were doing with scissors. Then in the beginning, we also believed that it was important even to do some cuts on the anterior and posterior wall. But the merit of this paper is it has been that after this paper, we saw a dramatical increase of scientific activity in for this kind of uterus. So probably everyone that was trying to treat these anomalies, and probably some of them, we knew that this anomaly was present, but we didn't know how to treat. We saw even at 3D sonography that it was possible to dramatically improving in a better way the morphology of our uterus. Then the mini resectoscope came on the market, and we saw that probably it was better to cut the isthmic rings by means of the hook electrodes on the lateral and right and lateral left wall. Then my fellow, that now she became my master, Ursula, described probably the possibility, even in terms of making a better job and even to make quicker the process. Sometimes using the cutting loop, you can remove these fibrotic rings in a better and more effective way. But we saw that it was possible to improve the shape of the uterus. Then I remember that I spoke with Grigoris, with Rudy. We saw that there were some other anomalies that maybe were a mixture of the T-shaped uterus and the septate uterus. And we cognated the word of Y uterus. And then my friend Luis with Tony Carugno published a great paper on JMIG where they were describing the criteria for Y uterus. So we understood that with this uterus, it was nice first to remove the fibrotic rings in the isthmic portion, and then at the end you have to refine the fundal area. So we have learned that thanks to the available instrumentation, we are able to improve the shape of this uterus. But even for this kind of anomalies, despite everyone is seeing that if we treat this uterus, the reproductive outcomes are going to improve, we know that there are many other groups that they say that probably this uterus is just a variant of a normal uterus, and there is no urgency to promote surgical intervention of these uteri. But I think that for dysmorphic uterus, we have a strong literature who is supporting maybe that the treatment, even because it's not a risky surgical treatment, we can do in outpatient setting with just a mild sedation. I think that this kind of surgery can dramatically improve the shape of our uterus, but mostly even to improve the microscopical environment of the endometrium, because we see that many ladies, and there is nearly a 30% of ladies with previous failed IVF, that after the treatment of this anomaly, they can get a pregnancy, even spontaneously. So probably I would leave you with this concept that every time we are going to treat uterine anomalies, and of course you have to treat when you have also to evaluate some cofactors important. No, please don't base your activity only on scientific literature, because scientific literature sometimes of good value cannot be present mostly when you are working in reproductive surgery. Evidence-based medicine, mostly reproductive surgery, is very important. You have also to consider patient wish. But I think that clinical expertise, which means also to evaluate the indication, the cofactors that can be present apart from the anomaly itself, are very important when you want to decide to treat or not to treat the anomaly. Thank you very much. And I'm ready for the question just in time. So, okay, good.
So we will receive one or two questions. If you have any question, please chat.
So please let me thank all people who are really connected. We are now more than 300.
320.
Considering that we are on Friday, that it's summertime for, at least for Mediterranean countries, it's a great, great result. And I think the importance of reproductive surgery once more is highlighted by the results of this webinar. So I think that there is a huge community who wants to know from we expert how to treat all the lesions that we can have inside the uterus and when to treat. So Grigoris, you and Rudy once more have had a great idea to arrange this webinar, and we thank Karl Storz for supporting once more all the educational activity that we as European community of gynecological endoscopy wants to promote now and forever.
So apart from the congratulations that you receive already,
I think that if
there are two or three questions.
There are?
Okay. Yeah, there are. What about the thick septum? What's your proposal? What do you have to do about that?
I don't know what does it mean, thick septum. Sometimes there are broad base septa, so that you see that there is a big base of the septum. Honestly, the technique does not change for me. I prefer, and I'm a strongly supporter of the use of electrosurgery. I strongly believe that if you use electrosurgery in the proper way, you are not going to create any damage inside the uterine cavity. But I mean, you can also use the scissors. I tried the new shaver from Karl Storz with 3mm instruments, and I have to tell you that the 3mm scissors works in a perfect way if you compare with 5 French scissors. So whatever is the instrument that you want to use, I think the technique of metroplasty is the same. I see my friend Rudy doing the treatment of dysmorphic uterus with scissors. He's a master of that. So you can use, if you want to cut the isthmic rings. I think that whatever is the instruments that you use, the technique and the landmarks, the anatomical landmarks that you have to respect are always the same. Then I think we can discuss which technique is the best. But I think that today that we have 3D sonography, we can, in an objective way, see if we did or not a good treatment of this anomaly.
So I will ignore, let's say a question. If you have to use unipolar or bipolar, I think that bipolar is now the energy that we have to use. But there is another interesting question, if there is any need to improve endometrial growth after resection, and if we have to do something for that.
No, honestly, I personally put gel to prevent intrauterine adhesions, because I think this can be, when you do the treatment of septate uterus or dysmorphic uterus, it can be an adhesiogenic procedure. So we, as endoscopic community of the European Society, we strongly believe in the importance of anti-adhesive gel within the uterine cavity. To be honest, I have never seen, touching wood, a lady in which I treated the septa, but I'm sure that Rudy, Luis, yourself, and Ursula, and all of us in literature present today, that we had a problem of the regrowth of the endometrium. So I can tell you that if you do an hysteroscopy after 2-3 months after hysteroscopic metroplasty, both for septate uterus or dysmorphic uterus, you still cannot recognize where you treat the septa or you did the cutting of the isthmic rings, because the endometrium is going to cover all the surgical wound without any problem. But the message of to prevent adhesion, I think it's very important. And I'm really proud that at the beginning, we were just few of us to support the use of anti-adhesive strategy. Now, more and more centers, I know that they use gel to prevent intrauterine adhesions.
So some technical questions, and we will finish with that. If anybody has any question, please, write, the Q&A, and then you will receive the answer by the speaker, by Attilio. So there are some technical questions. In outpatient clinics, because this is important, what kind of pre-medication to be given? What is the setting of the pressure? And how many times you need, to treat a septum?
Yeah, I think that this question I will send an answer to all these questions, because otherwise we go out of the time.
Yeah.
In outpatient setting, small septa can be treated without analgesia or anesthesia, but a mild sedation can be needed mostly when you have a broad-based septum. And of course, the pressure depends even on the pump, but the lower as possible. So the intrauterine pressure should be always lower than 50, 60 millimeter of mercury. And time is not important, because time, it also depends on instrumentation that you have. But all outpatient procedures, if the patient is awake, should last less than 15 minutes. Otherwise, the patient complains.
Okay, thank you very much, Attilio. We have to move now to Rudy Cambo, who will be the next speaker. And as we said before, how we can open the curtain, Rudy, looking inside the uterus. Please.
Thank you very much. After this enthusiastic talk of Attilio, I will try to give you a romantic talk of the uterus, and especially what is behind the curtain. So what is important in this talk is the inner myometrium. In our research moment of today, we believe that we have to explore more and more the inner myometrium and its function. And this MRI was shown us that the 3 functional zones, endometrium, number 2, the junctional zone myometrium, number 3, the outer myometrium, have their specific roles. And so what is quite interesting is to look for the question, when the inner myometrium, so number 2, which only differs from number 3 due to less water, more iron, different magnetic field, if this is disturbed, if this is disappeared, this junctional zone differentiation, if this has an importance in reproduction, and where hysteroscopy obviously is the direct access to this zone where hysteroscopy could play a role. The first question is study we did on egg donation patients, where we look normal ultrasound, normal hysteroscopy, normal MRI, and we look 2 years after the MRI, and we see 88% delivery, 2 miscarriage, and 2 non-implantation. Whereas, and you see the 7 MRIs, whereas we have a normal ultrasound, a normal hysteroscopy, but only MRI has a total loss of junctional zone differentiation. We do not have any delivery, although perfect embryological factor in the egg donation program, 4 miscarriages and 3 non-implantation. The second very interesting observation is what we did between 2010 and 2018. We just compare the normal junctional zone differentiation and the total loss of junctional zone differentiation in egg donation patients, and we see that the null hypothesis is rejected. Live birth is dependent of the junctional zone myometrium. In the normal, we only have 14% failure in the abnormal 61% failure. But modern ultrasound is the first choice tool to explore the uterus. There is no discussion. New technology is coming in and gives us information, important information, both on the endometrium, juxtazone myometrium, and outer myometrium. And we have my country fellow, Thierry van den Bosch, and the Dutch group has done a fantastic job on the adenomyosis classification. But the Dutch have also done an extremely good publication, which is extremely important. Transvaginal ultrasound does not meet the same imaging criteria as MRI. It has been shown clearly that the juxtazone, as it is seen in ultrasound, is not, this is the same patient in MRI, abnormal juxtazone, in ultrasound, normal juxtazone. So this makes things a little bit complicated. And so we come to the so-called, as we work in Belgium in the Life Expert Center, the combination of ultrasound, hysteroscopy, and tissue sampling. In a specific designed ambulatory care unit, we use the trophy, if necessary, but in adenomyosis, shaver is less important, the trophy and the mini bipolar resectoscope. And then we need sampling. I will not go into the sampling technology, but you have to understand that histology today is prehistorical. You need to work, or we need to work, into new histological approaches, like the Japanese have shown, that you have the rhizome under the glands, the basal layer, which is the plexus in the basal layer. So if you take a biopsy, you have to take a biopsy from this plexus, not only from the glands. But even more interesting is the work of Juan Geneco, Linda Griffith, and Keith Isaacson, in which they take whole tissue, then they do a whole mount cleaning procedure. So you see before and after, immunofluorescence staining, and then 3D reconstruction. And especially for adenomyosis, this gives us insight, and we can, here you see this typical adenomyotic lesion with the network of neovascularization. And if we go into the 3D modeling, then we can check every individual part of the lesion. We will now put the nerves, the white are the nerves of the lesion. We will put the capsula or the pseudocapsula, and we see that the nerves are behind the capsula and that there is an aberrant nerve invasion. So let's do some clinical work. The study concept is that we have to work single observer, single center, that we need a normal embryo factor, and that we have an imaging algorithm that we follow in the last 20 years, and every patient receives in the study protocol ultrasound, hysteroscopy, MRI, and every single exam is validated by the same examiner. So, what are the questions? If we find this simple lesion in MRI or in hysteroscopy and we remove it, has it any sense, or is it nonsense? If we have a generalized loss of juxtazone differentiation, what can we expect of medical treatment? And can hysteroscopic surgery, which has never been done until today in large series, remove large adenomyoma without creating an Asherman syndrome and with improvement of live birth rate? Those three questions we will address. The first question is, all egg donation patients, no embryo factor. We remove a focal lesion. You see the MRI has a normal juxtazone distribution, but have the anterior wall of focal lesion with a kystic part. We have 12 cases. We were surprised. 11 in 12 deliveries. One not pregnant. No miscarriages. Keep in mind, no miscarriages. The technique of those simple lesions, you see in hysteroscopy, you don't see anything. In MRI, you have a GPS, under ultrasound guidance. For this reason, in your OR, you should have permanent ultrasound integrated and high-tech ultrasound. And you go and you find fibrotic tissue and surrounding tissue. And when you give this fibrotic tissue and you have a good pathologist, he or she will tell you adenomyoma. And very surprising that those little lesions could play a role. So it's not like a myoma, it's more like a toxic substance, chronic inflammation that is removed. Second question, medical treatment. Obviously, if everything is black, if you don't have no reference in hysteroscopy or ultrasound to remove, you have no chance. So those patients received 3 months of DNRH analog, DNOGEST, and today they get also re-echo. But here we see that the results are not so enthusiastic. 17 patients, 9 deliveries, but here the miscarriage is a really problem in this population group, ectopic and 2 non-pregnant. All of those patients had normal hysteroscopic findings and ultrasound. That means no obvious pathology. So the large ones, my favorite. If you see those images in ultrasound and in MRI, hysteroscopy only a little bit of bulging, can you remove this? Is there a plane of cleavage? Should you do it mechanically or electrically? What are the risks during the surgery? And what will happen with a pregnancy, placenta increta, percreta, success rate? So we are doing a prospective observational study, and we only take the complex abnormal MRIs, the real implantation failure, they got everything. Again, the same methodology, single observer, cytoreductive surgery, and I will very standardized, and histology must confirm adenomyosis. 2 outcomes. First, is this surgery acceptable? Yes or no? Second, what is the pregnancy rate? The protocol, all patients have minimal 2 top blastocysts frozen, independently if they are young or if they are in a neck donation program. They minimally have 3 months of analogs, because most of them are over 6 months. The procedure after 1 month of medication is identification of the lesion, resection, local adjuvant therapy with platelet-rich plasma injection, application of HIA region, matter region gel, hyaluronic acid gel for anti-adhesive prophylaxis, and then 14 days before the stop of the medical treatment, so after approximately at the earliest 2.5 months, the control hysteroscopy with scratching, which is sidewall incision with the scissors, and application of HIA region, matter region gel supplemented with budesonide, which is cortisol. So the hysteroscopic diagnosis and treatment of the inner myometrium is either you see the bulging, easy, or with hydromassage, the subtle lesions, then you need an ultrasound reference, supplementary, or you don't see anything. Let's go to this one. We see here in ultrasound a clear lesion, not a big one. We see in hysteroscopy actually, except for maybe a criticism, here, a gland. But everybody would say normal hysteroscopy. Now we put at this position with concomitant ultrasound, bipolar needle, we put the coagulation current, and we see in ultrasound that this is the area, exactly the area where you have the cystic deformations and the change in tissue structure in ultrasound. Next step, resection in the midline. You cut in the middle of this lesion and you look, the cyst. You see cyst, so you take the cyst away, but you also see and recognize, and this has never been described until today, you recognize the adenomyotic tissue. And the adenomyotic tissue you can differentiate from the surrounding you call it pseudocapsula or whatever, but from the surrounding myometrium. And you have a visual reference and an ultrasound guide that you can cut until a certain depth, which looks the appropriate and removal of the fibrotic adenomyotic tissue. Once you have done the midline, we go to the sidewall. And there it is only possible to do this with the mini bipolar resectoscope. Don't do it with another one. You kill the patient and yourself, and you find this plane of cleavage, which is not the real capsula. We cannot speak about capsula. And we resect, I can believe you, the first case we did, we pissed in our pants, when I may say so, but you resect every tissue, everything. Don't leave diseased tissue. Simultaneous, and we do now intermittent transvaginal ultrasound measuring, and this is the end. The whole backyard, the whole posterior wall is removed. Oh my God. 8 weeks later, and they don't get estrogens, they are under GnRH analogs. We put the gel, sorry. And the gel we put always with the hysteroscope and through the outer sheet, and we do the ultrasound concomitant. After 8 weeks, I cannot believe it, no adhesions. This is the same patient. Tubulostia, your anatomical landmark. You go to the other side, little polyp. Interesting. The results. We have today 75 patients included in this prospective observational study. 46 received their second look hysteroscopy. We have no perioperative complications. All patients could leave the facility the same day. Only conscious sedation, so no intubation, no larynx mask, only oxygen. 14 patients needed a second intervention because the tumor was too large for the session, or there were multiple locations, and that is in the protocol forbidden, anterior posterior wall at the same time. All specimens were confirmed, and in 46 patients, there was not one with cavity obliterative adhesions. There were 3 cases of sidewall adhesions. And for the secondary outcome, today we have, from the 9 egg donation patients, 8 pregnancies, 1 miscarriage, 7 ongoing, 10 patients less than 38 with 2 perfect frozen blastocysts, with or without PGTA, 9 pregnancies, 2 miscarriages, and 7 ongoing. 6 deliveries today with normal birth weight, no complications, no placental disorders. This study, according to our knowledge, is the first prospective observational study to evaluate the feasibility and outcome of hysteroscopic resection of adenomyotic tissue in the inner myometrium. Those initial data, and we have another study which will be published very soon, which will be sent to FACSView and Vision in the next weeks. Those data are really reassuring and promising, demonstrating that hysteroscopic site-reductive surgery is safe, if you know how to do, with only minor postoperative adhesion formation, and that you have to use the mini bipolar resectoscope and anti-adhesive prophylaxis. We use also the budesonide prior to the embryo transfer. If you come to Marseille, which I invite you all, you will see the final results of this study. So my conclusion, dear friends, there is no doubt that today, if you are in infertility, working in fertility, you cannot without 3D ultrasound and hysteroscopy in the same room simultaneously to judge the organ, which is the most important organ for the carrying the pregnancy, the organ, to judge it. MRI has, in research purposes, an enormous added value. The algorithm is further worked out, and I think Stefan will publish the results that you really have with the 3 exams, a prognostic message for the patient. Diagnosis and treatment of subtle lesions, as Attila already said, is very controversial, but exploration of those lesions to explore the junctional zone seems very promising because you recognize adenomyotic lesions by hysteroscopy, the neovascularization, the different layers of the pseudocapsula. It is hysteroscopy who gives you the pathognomonic signs. Very difficult for the pathologist, extremely difficult to judge by MRI and ultrasound. So, dear friends, I hope you like this very much, or you liked it so much as I do. Hysteroscopy is a method of choice to explore the junctional zone myometrium, and it is really to discover the magic of reproduction. You have to open the curtain. See you in ESG Congress. Thank you.
Thank you, Rudy. Thank you, Rudy.
Congratulations. And as always, you give a lot of insight, even for people who are considered experts. So every time I listen to your talk, I'm tremendously impressed by the new idea that you always have. So there are some questions. Maybe it's something that probably, Rudy, you can just to summarize some questions. So the setting when you perform the subendometrial exploration up to the treatment of small focal adenomyoma, which is the setting that you use?
Our setting is for everything the same. An ambulatory care center outside the hospital with a high-tech operating room where we do conscious sedation level 3. Patient leaves the facility within 1 hour after surgery. If surgery exceeds, which sometimes in these cases does, 30 minutes, then we have to have the permission of the anesthesiologist, otherwise we cannot. No surgery above 1 hour. This does not work. If we have very large myoma, for example, or very vascularized placenta remnants, they go in the hospital. But this kind of pathology is all done in an ambulatory care center with conscious sedation, level 3.
And then they ask if you use anything after the treatment of adenomyosis, like estrogen tablet for the growth of endometrium.
Today, all the patients are under re-echo, which is regulorix with the estrogen progesterone. 3 months re-echo. In the first month surgery, before the end, 14 days before the end of the 3rd month, second surgery. If everything is okay, they stop re-echo, 5 days, they wait, and then they go for the substitution cycle for the cryopreserved embryo.
Always hysteroscopy, second look hysteroscopy, or if you have a 3D ultrasound to normal?
No, always second look hysteroscopy, and even in this study, all under sedation. We take biopsies.
And in all patients, I mean, you know, how you evaluate the endometrium in the second look hysteroscopy? You take a biopsy or just only hysteroscopically?
Ultrasound, hysteroscopy, and if anything is like you saw in the example, reddish endometrium, we take a grasping forceps biopsy. If you have a polyp, we remove the polyp, and we always do sidewall scratching to see if there is no adenomyosis. With the scissors, we don't use electricity at the second phase because the healing process of the carbonization of resection takes 8 weeks. If we do a second time surgery with the resectoscope, again, they have to wait 8 weeks. They continue with re-echo. Then we go for the second look hysteroscopy, only with scissors and gel.
So very nice. So this is also the treatment of
PRP.
GnRH antagonist is nice. I think that we can move, Grigoris, if you agree, on the next speaker. And it's a great pleasure to introduce Spanish people in this moment, mostly for football, are very happy. So after the winning of the European Cup. But Luis Alonso is also winning hysteroscopist in our community because he's the perfect compendium of clinical activities and scientific activity. Probably is one of the fewer people that I think is more passionate than me in hysteroscopy. And he likes this technique at all, and his talk are impressive. And I've never heard him speaking about cesarean scar defect. And so I'm curious, as all of you, to listen at him. And so, Luis, the stage is yours. So please impress all the community.
Okay, thank you, Attilio. Thank you very much. I don't know if I'm going to, because the expectations are too high after your words. And I want to thanks to the ESG and to Carl Storth for organizing this great webinar. I'm going to share my screen, and here it is. This is my topic: cesarean scar defects in patients with secondary infertility, when and how to treat. And I know that this is a webinar to talk about hysteroscopy, but you know that the treatment of this condition, it is not only related with hysteroscopy. But before go on, I want to highlight something. The latest available data indicates that 21.1% of women worldwide delivered by cesarean section. This means 1 in 5. But the problem is that the future estimation by the World Health Organization is that by 2030 will be in 6 years, around 28.5% of women worldwide will give birth by cesarean section. This is almost 1 in 3. And there are sometimes problems related with this C-section. Sometimes the healing process of the cesarean section scar is incomplete, and in that situation, there is a disruption in the myometrium at the site of the uterine scar. In 2019, an European task force defined the cesarean scar niche as an indentation at the site of the cesarean, of a previous cesarean section, with a depth of 2 millimeters. So keep in mind those 2 millimeters in the site of the C-section. This defect and its relation with some clinical symptoms, such as menorrhagia, abdominal pain, dyspareunia, and dysmenorrhea, was first described by Morris in 1995, using the term cesarean scar syndrome. But the very first paper I have found about the cesarean scar defect and the problems related with this condition is this paper from 1967. The title is in Spanish as Long-Term Complications of the Cesarean Section. And in this paper, Dr. Garcia Triviño, he stated that the etiologic essence of all post-cesarean complications lies in a pathological scar formation. So this is the first paper I have found talking about the problem, the abnormal healing of the scar. So the classic symptoms in patients with cesarean scar defect are the present. One of them is the presence of an abnormal post-menstrual bleeding lasting for 2 to 12 days. Usually is scant blood, is dark blood, and around 33% of women with a niche report this post-menstrual bleeding. This post-menstrual bleeding is more prevalent in women with a severe defect. You can see the picture in the middle with a severe defect. And the bleeding is related with a triple mechanism. There is some retained blood that keeps in that niche, in that hole, in that defect. There are an abnormal contractility of the myometrium around the cesarean scar defect, and there are some in situ production due to inflammation and that can cause that blood keeping inside. Another important symptom, one is the postmenstrual abnormal bleeding, and the other important for us is the subfertility or infertility, secondary infertility associated with the cesarean scar defect. Merely having a cesarean section reduce only for having a cesarean section the probability of getting pregnant by about 10% compared with women with a vaginal bleeding. However, C scar defects affect the fertility not only in cases of a spontaneous pregnancy, but also in cases of IVF, where there is a lower live birth rate compared with patients who delivered vaginally previously. So, the cesarean scar defect is related with abnormal uterine bleeding and with infertility, not to mention other problems like dysmenorrhea, chronic pelvic pain, and dyspareunia. This, keep in mind the retained blood, the poor contractility, and the in situ production. So we have to treat those patients with secondary infertility, that they have a cesarean scar defect, that they have that postmenstrual bleeding, and there is no other condition that can affect the fertility. For the treatment, and this is for me one of the most important parts, different options have been proposed for the treatment of this condition, both medical and surgical. The medical treatment is very important in patients who have no desire of getting pregnant. But in the treatment of this condition, and this applies to any disease, it is crucial to individualize the case and provide what we call personalized medicine tailored to the patient. And personalized medicine starts with a right diagnostic of this problem, mainly based in clinical symptoms and in the use of the 2D ultrasound. The niche is defined by the presence of an anechoic area, usually with a triangular shape at the site of the previous cesarean section, in which we have to define the length, the height, and rotating our proof 90 degrees, the width and the existence of branch. And probably the most important part is what you can see in the picture, the residual myometrial thickness. Because depending on this residual myometrial thickness, we will choose one or other kind of surgery. It is important to highlight that the best time to perform the diagnosis by ultrasound is during the late proliferative phase, in which there are cervical mucus within the niche, or if we can't see it properly, what we can do is to put some saline inside and perform a sonohysterography, as you can see. This is the same case after putting some saline inside. Of course, the use of 3D ultrasound, especially the sonohyster 3D, facilitates the study of the defect in multiple planes and often provides more information than conventional ultrasonography. You can see that that is the niche. But for me, the best method, of course, is hysteroscopy. So hysteroscopy plays an important, essential role in the diagnostic of this condition. Hysteroscopy allows for a direct visualization of the defect. And during the hysteroscopy, what we see is a pseudocavity in the anterior wall of the lower uterine segment or in the upper third of the cervical canal. And we can see like a double arc and space in between. Regarding the treatment options, they depend on different factors. However, the treatment should be reserved for symptomatic women. Surgical options will be considered for those with infertility and no other condition that affect to the fertility. And I like to divide them into two groups, what they call reparative surgery and what they call symptomatic surgery. Reparative techniques aim to restore the normal uterine anatomy at the level of the cesarean scar defect, while symptomatic techniques focus on reducing the symptoms without restoring the normal anatomy. So I will start with the reparative surgery, and one of this type is the transvaginal repair. It is indicated in symptomatic hysmocele with less than 2.5 millimeters of residual myometrium, both in abnormal uterine bleeding and in patients with secondary infertility, and in cases of low location of the isthmus heels or patient with high elasticity of the tissue. So what we do is first we grasp the cervix with a tenaculum, then we made an incision in the cervical vaginal reflection. The bladder is dissected away to open the vesico-vaginal space and to reach the peritoneum. Third, I use a uterine sound and I place it into the defect. I push that sound in order to identify the exact location of the defect. Therefore, the defect is totally resected using the monopolar electric scalpel. You can see the piece that I have resected. And lastly, I close with vicryl in 2 layers, and finally, I close the vaginal mucosa. So here are summarized the 6 steps that we use in the vaginal route. Another reparative technique, of course, the laparoscopic repair. The indications: symptomatic isthmus, less than 2.5 millimeters of residual myometrium, both in abnormal uterine bleeding and in patients with secondary infertility, and in cases of high isthmus or in patients with not too much elasticity that we cannot use the vaginal route. So 6 steps. 1, the identification of the uterus, the bladder, and the isthmic area. 2nd, opening the peritoneum over the vesico-uterine fold and dissecting the bladder, separating it from the uterus. Then we have to identify the exact location of the defect. For this, we can use a proof, or we can use an hysteroscopy. We can see the light of the hysteroscopy in that area. The next step is the total excision of the defect, including the fibrotic tissue, and then we close the defect with 2 layers, and the final step is close the peritoneum. So again, here you have summarized the laparoscopic repair with the 6 steps that we usually use. And regarding what I call the symptomatic technique, we have the hysteroscopic treatment, the surgery to treat the symptoms, but not to restore the normal anatomy of the defect. Indications: symptomatic isthmus, more than 2.5 residual myometrial thickness. This is important, both in cases of abnormal uterine bleeding and in patients with secondary infertility. I prefer to perform this technique, and I think that today is mandatory with miniaturized instruments, the mini resectoscope, because we avoid the dilation of the cervix that can affect to the normal anatomy of the niche and make it more plain. In this case, we have to follow 5 steps. First, identification of the defect and visualization of the proximal and the distal part of the niche. Second, resection of the proximal arc. Then there are variants. We can fulgurate, or we can resect the distal arc. Then we have to fulgurate the entire niche dome, because there are some inflammatory tissue that can, as I told you before, can be related with that in situ production. And finally, as Paolo Casadillo said, the 360 degrees fulguration in order to treat all the inflammatory mucosa located near the defect. So one more time, here you have the pictures of those 5 steps. In summary, the sudden scar defects in patients with secondary infertility, coming back to the title of the lecture, when they should be reserved for symptomatic isthmus, and how should be decided based on the patient's symptoms and plans for future childbearing. And in cases in which we need surgery, keep in mind those 2.5 millimeters of residual myometrial thickness. So, and coming back to this slide, it is in cases of symptomatic cesarean scar defect, it is crucial to individualize the case and to provide personalized medicine tailored to the patient. Thank you very much.
Thank you, Luis.
So you see, Grigoris, the peak of attendance during the webinar is when our Spanish friend speaks. So
350,
so
350.
But this is for the tennis.
And no question, because it means that our people are fascinated by talk, that they do not want to waste any word. So, Rudy, there are some questions for you that probably I will ask to send you directly, because I think that they need an answer, mostly about PRP and something similar.
I'm already answering.
Okay, you already answered. So,
He's busy.
okay, probably there is one question just for Luis. If you think that the ismo cell, this is nice, can be treated by shaver. So do you think that there is any place for the ismoplasty by shaver, or every tissue removal device, I suppose? So
yeah, I think that it is important to you know, we have to try to find the best tool for the different conditions. So shaver, I think that have their indications that are great, but probably this is not one of the indications for the shaver. Of course, you can resect the lower arc with the shaver, you can do it, but you have no way to fulgurate all the tissue that you have over in the dome of the defect or the tissue that you have in the lower part. So you can use the shaver, but probably you have to use another tool to fulgurate the tissue that will be a mini resectoscope. So why to use two instruments to do the same job, you know, when you can do by one? Something that I want to highlight, and I think is important regarding this lecture, is that hysteroscopy is essential in the treatment of some cases of cesarean scar defects, but not, in my opinion, for all the cases of cesarean scar defects. So at least you have to manage a couple of them. You have to be able to perform maybe hysteroscopy and laparoscopy, where are the more easy, or if you are a good vaginal surgeon, you can use the vaginal route. No, but you have to use at least two, or to have another doctor that work with you who perform the laparoscopic part or the robotic if you are lucky and you have a robot in your OR. But at least two, because if you only do by hysteroscopy, not all the cases can be done by hysteroscopy, and sometimes if you treat by hysteroscopy, the results are no good. The patient still have some blood inside, some blood that go to the cavity and to affect to the normal endometrium with inflammation and so that's my recommendation, my last recommendation.
And Luis, just if you can emphasize a concept that I remember it was difficult to understand even for me at the beginning of my hysteroscopic trip. So why, if the ismo cell is only located in the anterior wall, then we treat 360 degree? If you can express in few words this concept.
Yeah.
People always think bidimensionally, not three-dimensionally.
Yeah, the first technique was the one by Fernandez from Chile. Then there was a variation by Fabres with the resection of the posterior wall, and then this variation that was proposed by Paolo Casadillo and Gian Pietro. And what they say is that there are some inflammation in that tissue, because when we see with our hysteroscope, we are distending the cavity, and there is no contact between the anterior and the posterior walls of the cervix. But the truth is that is in contact, and the blood that is keeping in the niche is touching the posterior wall. So there is some inflammation in that area. What they want to do with this 360-degree technique is to remove in any way that inflammatory tissue. Instead of cutting or removing with a loop, what they do is a fulguration with a 1 millimeter depth only. So we take away that inflammatory tissue, and the aim is that the next tissue that will grow in the next month is a normal one without that inflammation.
Thank you very much, Luis.
You're welcome.
Doris,
There is a lot of interest, Luis.
so you have to introduce.
Thank you, Grigoris.
Yeah. Thank you very much. Congratulations, Luis. You have a lot of job, because if you see, there are some questions still that
Yeah, many questions, many.
So
I will start right
please answer, I mean, by to the questions. So
Okay,
it's really, my honor to present the next speaker, which is Ursula Catena. Ursula is leading, our seat of Hysteroscopy in SGE. She is really, very enthusiastic on that. She has a lot of ideas, and she is leading also a lot of projects in hysteroscopy. Initially, actually, we were thinking, to present by her the fibroids, but later we decided, this is why, in the initial my presentation I spoke about fibroids, but we selected another topic which is really very hot and very interesting, and Ursula probably is the best in the field, working in polyclinical gemelli. So it's the random diagnosis of endometrial cancer during the fertility workup, what to do, and if there is any chance of uterine preserving treatment, and what is the role, of hysteroscopy on that. Ursula.
Thank you very much for the introduction. It's a really, really big pleasure to be here with you today and to have the possibility to speak after this very big boss of hysteroscopy. So it's a very hot topic, surely. And if we start in general, we deal all the day of our life, of our clinical life, with the patient that cannot succeed to conceive. And if we see the guidelines of ESHRE on unexplained infertility, and as also the other colleagues showing us about other topics, but if we see these guidelines about the diagnosis on uterine infertility factor, we can see that it is recommended to perform ultrasound, 3D ultrasound, to exclude the uterine anomalies in women with unexplained infertility. MRI is not recommended, but if ultrasound assessment of the uterine cavity is normal, no further evaluation is needed. But we really think that there is no place for hysteroscopy in patients with unexplained infertility. I want to show a case. This is an ultrasonographic assessment of a patient sent to us for checking the uterine cavity for infertility. We can see that the endometrial line is quite okay. If we put color Doppler on this endometrial line, we can see that something arises with a little bit of higher vascularization. But what we think, if ultrasound assessment of the uterine cavity is normal and no further evaluation is needed, we think that in a case like this, we not recommend hysteroscopy for this infertile patient. And let's see what there is inside the uterus of this patient. I think that everybody of us in this patient hysteroscopically can recognize this focal endometrial cancer. So it is a thing that happens, surely not frequently, but it happens to find small endometrial cancer inside the uterus of these patients or focal endometrial hyperplasia. So what we have to do in this patient? Surely in January 2023, finally, after a lot of efforts by our three societies, we succeed in having our joint guideline between ESG, ESGO, and ESHRE about the fertility-sparing treatment of patients with endometrial cancer. Surely, in this case, we have to face a very bad situation because we have in front of us a patient that is infertile, a couple that does not succeed in conceive, and we have also to tell to this patient and to this couple that this lady have an endometrial cancer and we have to manage in such a way. First of all, the counseling is fundamental. So we have, first of all, inform the patients that fertility-sparing treatment is not considered the standard of care for endometrial cancer because the standard of care is total hysterectomy with bilateral salpingo oophorectomy with the lymph nodes assessment that have to be considered the recommended treatment to treat definitely that patient. Women undergoing fertility-sparing treatment should be encouraged and know that they have actively aimed to conceive as soon as the complete response of fertility-sparing treatment is achieved. In any case, radical surgery is mandatory after completing childbearing or in case of non-response to the treatment. What is the treatment? Finally, in our guidelines, we can see that a combined approach consisting of hysteroscopic tumor resection followed by progestins is the most effective fertility-sparing treatment in terms of complete response rate and live birth rates. We can see this meta-analysis published already in 2017, in which we can see how it is completely different, the complete response rate, if we use hysteroscopic resection followed by progestins, more than 95%. If we compare to progestins alone, we are about around 70-75% of complete response rate. But we have to consider which patients are eligible for conservative treatment. So we have to have patients surely who want to have a baby and we have to consider it, the grade, the stage, and the histology of the disease. So we have to face with the patients with endometrial cancer in less than 42 years old who planning to achieve a pregnancy soon after the disease regression. We have to have a well-differentiated endometrioid adenocarcinoma with no evidence of myometrial invasion, cervical extension, and pelvic or para-aortic lymphadenopathy, and normal annex. What is the surgical management of this patient? Surely also in this case, as also for metroplasty, as Attilio showed you, the evolution of hysteroscopy has completely changed the way in which we approach these patients. Some years ago, we just had the possibility to treat this patient after hysteroscopic diagnosis with monopolar 26 French resectoscope. Then, with the introduction of miniaturized instrument and in particular with the introduction of tissue removal devices and bipolar 15 French mini resectoscope, we can see in the next slides how it is nowadays different, the treatment of patients with atypical endometrial hyperplasia and endometrial cancer. The first one who described the technique was Ivan Mazzon in 2005, in which he tell us that he discussed this with my actual chief, Professor Scambia, because he had this idea to treat a focal lesion in a young patient with first stage endometrial cancer, and he had the idea to remove the lesion before starting progestin therapy. And what is at that time, the technique that we used until today? He described this three-step hysteroscopic resection. So first of all, removal of the endometrial cancer. This was one of the first video of Attilio about this technique, in which we went to remove the lesion. At that time, we did with a 26 French resectoscope. The second step is to remove the endometrium near to the lesion for 4-5 millimeters. The third step is to remove the myometrium under the lesion for 3-4 millimeters. And then we perform random biopsies on the other walls of the uterus. Which are the novelties with our new devices? Surely nowadays we use the same technique that Ivan Mazzon described, but we use a 15 French bipolar mini resectoscope that allow us to avoid the dilation of the cervical canal and to be more conservative in the uterine cavity of our patients, because we have to remember that in this uterus afterward we aim to have a pregnancy inside. So if we use too strong instrument inside the uterine cavity, afterward we damage irreversibly the uterus of our patients. So nowadays, normally for a focal lesion, I always use a 15 French mini resectoscope with the same technique. So removal of the lesion, removal of the endometrium adjacent to the lesion, and the removal of the myometrium under the lesion. And then we performed random biopsy in the other part of the uterus. And you can see which good results you can have with this kind of instrument. We normally perform on all the other walls of the uterus random biopsy, and we send it separately for histology. This is another paper published some years ago from the group of Attilio. This was surely interesting for the data, but the more interesting thing was that for the first time, Attilio and this group described this technique in which we starting to remove atypical endometrial hyperplasia, preserving the basal layer of the endometrium. At that time, we use energy to do this job, and you see these small dots that are the base of the glands, and this is interesting because this opens the idea to Paolo Casadio to describe what we now call visual DNC, that is the use of tissue removal device to treat atypical endometrial hyperplasia. Look at this endometrium. If we have this endometrium in patients during their fertility workup, surely we have to study this endometrium, and in the majority of case, we found a thickened polypoid endometrium inside the uterine cavity. And what to do? We perform this technique that is visual DNC. So with a tissue removal device, we completely remove the thickened endometrium. And at the end of procedure, just after the use of the tissue removal device, we position a levonorgestrel IUD inside the uterus of our patients, and we block the regrowth of atypical polypoid tissue. So you see that you can completely remove the polypoid thickened endometrium. And you can do the job on all the walls of the uterine cavity. With this instrument, that is a totally mechanical instrument, we have no risk of intrauterine adhesions, and after the stopping of progestin therapy, the endometrium starting to regrow, and it is a totally normal endometrium because we have never treated with electrosurgery that uterus. And I want to show you the final view of the uterus after the complete visual DNC. What is the therapy that we give to our patients? Is surely progestin therapy. This is our internal protocol. So for fertility-sparing treatment in patients with G1 endometrial cancer and atypical endometrial hyperplasia, we use hysteroscopic resection followed by levonorgestrel IUD. If patients have stable disease or progression after 9 months or partial response after 9 months, we add megestrol acetate 160 milligrams given orally. If on the immunohistochemistry they have a mismatch repair status deficient, we surely perform genetic counseling, and they were treated as G2 endometrial cancer that are all treated from the beginning by hysteroscopic resection plus levonorgestrel IUD and megestrol acetate 160 milligrams given orally per day. How we follow up our patient. This was a nice review that I did with Attilio, in which we described the follow-up of our patients, that is endometrial biopsy every 3 months for 2 times, then every 6 months for 2 times, and then every 12 months. Surely if patients are not yet ready for get pregnant, because sometimes we see patients that have 20, 21 years old. And in the video, you can see that it's very easy with miniaturized instrument and grasping forceps to perform biopsy with the Mirena inside the uterine cavity. So no necessity to remove every time Mirena, but it is a procedure that we perform totally in an office setting with the patients awake, very few minutes procedure. And what about G2 endometrial cancer? It is described inside the guidelines that we can start it to treat in selected center patients with early stage G2 endometrioid adenocarcinoma or with G1 endometrioid adenocarcinoma with the minimal myometrial invasion, 1-2 millimeters. And it is totally my pleasure to show the technique that I described for these patients treated for diffuse endometrial cancer. This was a patient with diffuse G2 endometrial cancer, in which I described for the first time this combined technique, in which I used the 15 French mini resectoscope to remove the main lesion until the myometrium, and then to resect all the pathological endometrium in difficult areas, as for example near to the tubal ostia, or to in general not use energy in all the uterine cavity. I complete the resection inside the uterus with a tissue removal device. So you see here near to the ostia, it is very difficult to completely remove that tissue. So I decided to start to treat with this combined technique. With the tissue removal device, you can easily reach this area, completely clean that areas that you cannot treat even with the 15 French mini resectoscope, and you can completely free the cavity from pathological tissue. This patient then started, as I showed you before, double therapy. So soon after the end of the surgery, I put a levonorgestrel IUD inside, and they started megestrol acetate 160 milligrams orally per day. You see here with the rotation of the tissue removal device near to the tubal ostia, you can completely remove the pathological endometrium. And this is the final view soon after the end of the surgery, and we put the Mirena inside the uterus. These patients had the negative biopsy at 3 and 6 months, but I show you the video because I want to underline that with this technique, you have a completely free myelina inside the uterine cavity, so no adhesion. We remember that when we treated the patient with 26 French monopolar resectoscope, sometimes we found the levonorgestrel IUD completely closed inside the uterine cavity. With this technique, we succeed in completely avoiding this. So I want to conclude with this nice picture. This is under publication, so I have the possibility from ESGO to be invited to publish this flow chart on the decision-making series for early stage endometrial cancer. And here we can see what is the way in which we treat these patients. So as we show for focal tumor, we perform hysteroscopic 3-step technique. For diffuse tumor, we use combined hysteroscopic resection, so 15 French bipolar mini resectoscope plus tissue removal device. In all patients, obviously, we perform histological diagnosis and immunohistochemistry. In G1 patient, we put a levonorgestrel IUD inside the uterus. For G2 cancer, obviously, we have a totally strong counseling for these patients. And for G1 mismatch repair deficient, we perform directly double therapy, levonorgestrel IUD and megestrol acetate. And our follow-up is office hysteroscopy, endometrial biopsy every 3 months. After 2 consecutive negative biopsy, patients who are ready to starting to try to conceive will do it. Otherwise, for if they are not ready, they go on with the biopsy every 6 months. And I want to conclude with this nice picture. This I thank the patients for giving me the possibility to publish. This was the first spontaneous pregnancy after the treatment of G2 diffuse cancer, and they are a very nice family. Now she removed the uterus, surely, and I want to thank her and all my patients to give me the possibility to help them. Thank you.
Thank you very much, Ursula. Very impressive. We have just time only for one question. This is really a new field. I think here it's also impressive that there is a real role of hysteroscopy in the treatment of patients with endometrial cancer, if you would like to make a uterus preserving therapy. So what about the dissemination of endometrial cancer cells in the peritoneal cavity? A big discussion, and afterwards, after your answer, Attilio will present the next speaker, which will be Luca Gianarolli.
So there is a big discussion on this, but there are also a lot of papers that surely some cells can pass in the peritoneum, but this does not come the final outcomes of our patients. So in our center, we treat all these patients by hysteroscopy, and also all the patients who perform radical surgery before have an hysteroscopic assessment of the uterine cavity without any change of their outcomes, oncological outcomes for this.
Attilio.
Okay, how can I introduce Luca Gianarolli?
The big boss of ART.
Yeah, no, I think that if I have to think someone who represents the real connection between the world of reproduction and the world of endoscopy. Since I was a child, in this world, I thought about Rudy and Luca Gianarolli. I think that is one of the most brilliant minds that we have in our gynecological community. And in the last 6 months, I have the honor to consider him and to be considered by him as a friend more than a colleague, and I'm very proud of that. And I think that with his help, the role of reproductive surgery can definitely reach the right position that it deserves. And Luca has to help us to reach this objective. Luca, did you disappear after my introduction? So you are so embarrassed? What's happened?
Oh, I'm here. So thank you very much for your introduction. Please let me know when the number of attendees will go below 50, because up to now, the meeting was very successful, but you never know once that I start. And I have also to let our audience know that according to your presentation, if I am the best in reproductive ART, can you imagine the others? So we are really facing a big problem at the moment. So I just want to jump some of the technicalities, because you have already we have already gone through this during the seminar. I just want to leave to you some points for this presentation that I've done, also thanks to other two co-authors that have helped me to collect the data and prepare the slide. So, first of all, I would like to go on, but the slide do not go further. So that is a technical problem, I suppose. Here we are. You see here that after 6 cycles of treatment, even if we are talking about data that are older than 10 years, you still have 85% of the patients that can deliver. I'm not talking about getting pregnant, but delivery. So our major issue is to avoid the patients, once they enter ART treatment, to drop out. They can drop out for financial reasons, for psychological factors, for unrealistic expectations, and I'll go back to this, and for repeated IVF failures in general. So why I'm saying this and why hysteroscopy is important? Because if we forget for one moment the 2 previous points, we go for unrealistic expectation. The fact is that we are still producing data based on cycle results or cumulative pregnancy rate, while we should use, in fact, what the oncology use, or the concept of life tables. And when a patient fails more than once, we should then we go to a better accuracy in terms of diagnosis, not only for patients, but also for gametes and for embryos. So the point here is that we should do this via the use of investigating what is the counterpart that play more than 20-30% of chance to be successful, but it plays in fact 50%, that is the uterus. And the only way which we can work on the uterus is to look inside the uterus. First of all, we have to consider that the same uterine pathology is different if the patient can conceive naturally or if the patient has to conceive via ART. Why I'm saying this? Because the only chance for a patient to conceive via ART is the chance that we give to her when we transfer one embryo, while the patient that could conceive naturally, in fact, she can do every month that she has timed intercourse. If we look at the technique itself and we concentrate on the embryo transfer, even the technique of embryo transfer, they look to be very simple technique, in fact, can become difficult and can, in one way or another, jeopardize the whole work that has been done before, but even worse, all the expectations of the couple and all the expectation of the patients. So we have different instruments that can help us to overcome the difficult transfer, but I want to stress that one transfer out of 20, one transfer out of 25, one transfer out of 15 can be a difficult transfer, mainly if the cervical canal has not been studied. So hysteroscopy before ART has also a different indication from those that is looking for pathology, but it's the study of the cervical canal before embryo transfer is done. I don't want to enter the discussion if hysteroscopy is better than ultrasonography for uterine cavity evaluation. There are many papers that you can look around. The only thing that I can say, as it was very nicely described from the previous speaker, is that you have the chance in the meantime to do proper biopsy and to have studied properly the cavity via histology. Again, when we look at the difference in terms of transvaginal ultrasonography and disc hysteroscopy in terms of inner pathology, and you compare sensibility, specificity, positive predictive value, negative predictive value, and accuracy, again, of course, since you see directly, this is in favor of hysteroscopy. And what we should change is the paradigm that we are still advocating to do diagnostic hysteroscopy. If you want to use this tool before ART, we should talk, and I will be back to this if I have time, to the concept not of diagnostic hysteroscopy, but to use hysteroscopy as a screening tool. Screening tool for treatment of intrauterine pathology, and as I mentioned to you before, also for the cervix. Cervixes that play an extremely important role in our activities. Again, without wasting too much time, we should also take into consideration that it could be an effect that is independent of the treatment of the intrauterine pathology that has been highlighted by papers coming from the so-called endometrial scratching. Endometrial receptivity can change if scratching is being done, and hysteroscopy done the 1, 2, 3 months before the potential embryo transfer could also act as a system for endometrial scratching. And papers and literature are in one way or another convincing us that this could also be an extra opportunity for hysteroscopy. Not to say about the focal hyperplasia that has been discussed, the chronic endometritis, the dysfunctional endometriums are part of the endometrial polyp. On the endometrial polyp, I don't want, again, to waste too much time, but please do not believe that the size of the polyp is strictly related to the unsuccessful story of an IVF embryo transfer. We should never forget that a polyp of 2-3 millimeters in a virtual cavity, in fact, occupies most of the cavity when it's positioned just after the inner uterine osteums. And most of the time, if a small polyp is there, what we are going to do is to transfer our beautiful blastocyst, may be generated after pre-implantation genetic testing, in not in the endometrium, but inside the polyps. No more to say about the alteration of the polyps, not only from the physical point of view, but from the anatomy point of view, functional point of view, endocrine point of view, and paracrine molecular effects. So this small pathologies could really play a negative role in different way, as they do myomas. Again, I think that none of the people that are attending this meeting have doubt about the fact that submucosal myomas, that is true, are seen at ultrasound, but they are not properly evaluated without hysteroscopy, play a negative role. There are many doubts about intramural myomas, and again, I don't want to spend time on this, but I just want to underline that even a small protuberation of a figure 3 myoma could play a negative role at the time of implantation. I think that one of the neglected part of our understanding in failure of implantation is also related to adenomyosis. We have heard by Rudy many important pieces of information. What I want to say is that if a chromosomally normal embryo of a young woman has a potential of implanting and give rise to a live birth are between 40 and 45% each time that see a normal uterine cavity, if after 2/3 transfer this has not happened and we have any sign of adenomyosis that should have been diagnosed earlier than doing the transfer, for sure you have to blame the uterine pathology and not ART as a technique itself. Not to say anything regarding what it has been said by Alonso. Here you have a summary of the difficulties of the transfer and on the time spent for the transfer, on the retained embryo in the catheter, when you compare patients that have previously delivered vaginally or that had a cesarean section before. As you can see, many of the most important items, including mucus on the catheters that can trap the embryo, are significantly different in the two groups. So once again, the evaluation of ismocell is play a dramatically important role. It's true that most of the time we don't need to have hysteroscopy performed to detect congenital uterine anomalies, but it's true that, as was being clearly said before, since each septum or subseptum is completely different, to have the opportunity to check on that by forceps or by simple instruments that can be done during diagnostic hysteroscopy could play an important role also to decide if you want to remove or not this abnormality. Again, taking into consideration that patients that require ART are different from patients that could conceive naturally. This is a study that has been carried out by Manzi, that is a fellow at Federico II University in Naples with Attilio Di Spezia, that spent time with us. He collected and he did by himself data for which, before doing a diagnostic simple hysteroscopy, he was making a monk embryo transfer using 10, 20 microliters of methylene blue and then performing the diagnostic hysteroscopy. During this study, he also went through some pathologies. As you can see, for instance, a very easy embryo transfer done on the right. And when you enter, you cannot see any methylene blue, any dye test. And when the hysteroscope is retracted, what you can see is that the 10 microliters potentially containing the embryos have been discharged at the top of a polyp that is not bigger than 2 millimeters. This is only to say how a small pathology can jeopardize all the work that has been done before. He divided the patients in 3 groups: those patients that had methylene blue that fill the cavity in the reaches the fundus, methylene blue that fill the cavity, and methylene blue that fill only a part of the cavity or doesn't fill at all. All the transfer will be considered to be easy transfer, easy to perform. So these 3 categories have been then compared among them, and with the primary objective assessing the ability of this technology to predict reproductive outcomes of embryo transfer. Then patients that you can see on the left table, around more than 600 patients with more than 1,000 cycles, they were divided in these 3 groups. And as you can see, the 3 groups, in fact, are similar in terms of age, in terms of BMI, and in terms of menstrual cycle day in which the monk embryo transfer and the same consequent hysteroscopy has been done. And here you see clearly the results that despite all the embryo transfer looked absolutely easy and normal to be performed, there is a huge difference in terms of implantation rate and in terms of clinical rate when the 10, 20 microliters of potential media have reached completely the cavity without being just trapped in part of the cavity or being not even entering the cavity without, once again, the transfer was performed and considered as an easy transfer. So this is just an example to say how diagnostic hysteroscopy could also play a role in forming new students or in having the possibility to check if you are in training, your transfer is done correctly. This is a paper that all of us have read that summarize what I have just said. And so there is not much to add, if not the need to perform these simple exams before. And this is an example, a 25 years old woman, as you can see, 3D ultrasound with ultrasonography, perfect uterus, perfect tubes. You do your monk embryo transfer, then you enter the cavity, and I'd like you to have a look also on the left at the 3D. Once that you reach the cavity with a small stenosis of the, you see a nice, huge vertical adhesions that is breaking just using the pressure of the water to do the hysteroscopy. Again, look at the left side of the screen. Tell me if you can see anything that could make you to suspect that there was such an adhesion in a woman that never had pregnancy before, never had termination of pregnancy, never had, according to her, any infection. So I like to conclude saying that we should think about hysteroscopic as a diagnostic tool for screening in reproductive medicine. According to what has been defined as screening, not only in Wikipedia, but also by Wald in this paper, is the systematic application of a test or inquiry to identify individuals at sufficient risk of a specific disorder, like our infertile patients are. And this has nothing to do with the diagnostic test. So we should stop in ART to call hysteroscopy a diagnostic tool, but we should go for a screening of our patients. So all in all, to conclude, this is what we have in our hands. Recent studies have highlighted that treatment of intracavitary pathologies is recommended to improve reproductive outcomes. Currently, the guidelines do not recommend the routine use of hysteroscopy in IVF, but we should consider, despite its only focus on a strong indication for recurrent implantation failure, we should consider hysteroscopy as a test, as a screening test. So that's the way which we should use this tool before IVF programs are set up. Thank you very much for your time. And since I was not interrupted by Rudy, it's possible that the audience is still up over 50 attendees.
So, Luca, congratulations. So, I think that all people, an average of 300 people followed our webinar. I think this is one of the most well-attended webinars. So I think that the topic, it was incredibly attractive. And I have to tell you that this is another good choice of Grigoris and Rudy when they decided with Ursula's leading of the SIGIN hysteroscopy to arrange this webinar. We were actor of this webinar, but they were the movie makers. So they had a great idea. And personal opinion, I've seen that there are people connected from Singapore, China, Middle East, United States. So probably most of the questions come from these countries. So our society is becoming more and more out of the borders of Europe, and this is honestly, I feel very proud as member of the EXE of this society. And Grigoris, do you want to say something?
Yes. First of all, I would like to thank Storz giving us the opportunity to organize this. Second, I would like just to thank you all, especially the speakers, for their presentations. I know that this is a huge work to prepare a very nice presentation. And for me, I was thinking all this time, what is the difference of this webinar compared to other webinars that we did for reproductive surgery or maybe hysteroscopy. So I think the main difference is that and this is why this webinar was attractive, is that, we didn't repeat actually what we know. In this webinar, I think that there were a lot of new knowledge. Just, let's say to say that you had the opportunity to present what is new in the treatment of septate uterus and also, of dysmorphic uterus, because we were thinking that just only cutting a septum, this was the solution, but there is a lot of knowledge behind. So Rudy, one of the masters of hysteroscopy, presented what is happening behind the endometrium, and also with adenomyosis, and we had some new knowledge and how we have, let's say, to deal with this problem, during hysteroscopy. This is really a new topic. And Luis present us, about cesarean scar defects, and I really love the way that you presented. And I love, let's say, the classification of the treatment. The reparative treatment and also, the symptomatic treatment. And it's important that you mention that hysteroscopy is a symptomatic treatment, but we have to stay to the symptoms, and we have to treat symptoms, not the cesarean scar defect per se. Then we have Ursula, who presented, about endometrial cancer, which is, a very hot topic. The three societies, the European Society of Gynecological Endoscopy, the European Society of Human Reproduction and Embryology, and also the ESGO, prepared a very nice guideline about the treatment. And there was a very big contribution of our SIG hysteroscopy. This is really, something that it was also mentioned. And finally, we had Luca, who presented, why hysteroscopy is an obsolete tool. Let's say up to now, let's say to the IVF patients, and why we have, to focus, for the infertile women to evaluate the uterus, because it's not only the embryo. If you have a very good embryo and you put it in an abnormal cavity or a non-functional cavity, you will not have the result that you want. And this is actually what we are thinking in ESGE. After the H. artus, ESGE is moving, and is moving in a new concept. We will move now from the techniques to the patient. So we have to look from now on, not only, to endoscopic techniques, but to the patient who receive endoscopy as a solution to her problem. And there, we have to have a multidisciplinary approach. And for reproductive medicine, that means that ART has to go hand by hand, with endoscopy and also ultrasound. And this will be the new concept, and we are working on that. Thank you all for your contribution. I think that, it was really a very successful webinar, and not only because of the participation of up to 350 real participants, but also for the quality of the lectures and for the new ideas that we have.
Thank you, Grigoris, for sharing this session. You were the master, and we are here for you. So thank you very much.
Thank you.
Yeah, thank you very much. Great
Bye-bye.
opportunity.
Thank you.
Bye-bye.
Bye.
Più
Ciao.
bello Luca.
Bye bye.